I'd like to call you in from recess, and I think I'd like to get this panel started. And for those of you who haven't noticed the difference, I'm not Richard Kipp. I'm Dave Merkin from Millman. Richard's one of my colleagues who was unable to be here. And like all the moderators, I'm on the advisory board for the center. And so they've pressed me into service. One of the things that they don't know, since I'm the moderator, I can say anything I want. And I do have a couple sort of introductory remarks for this session, which is, I think, I've been associated with VBID for a long time, long enough to see Mike Cherno's hair turn gray. And Mark hasn't lost any more hair, which I don't think is fair. But it has been a long time, and I've been privileged to sort of see a major evolution both in the adoption of the principle, but also just in the caliber of the individuals who come to these kinds of meetings that they interact with. And I think that Mark and the current center deserve all the credit for that. I don't want to leave Mike out, but he's not part of the group anymore, right? Is that anyway? Now, VBID itself it's a great idea, but I think it brings with it a lot of, if you want to think of it just business or administrative challenges that theoretically technology ought to help us with. And I've thought of sort of three key areas. One is it might sound really simple, but designing really a true VBID benefit design or benefit plan that meets all the criteria that the center has set out is not easy. And I think technology can help us with tools for that. Administering what a VBID design is complicated, and I think technology hopefully can help with that. And then there's sort of another area that I think maybe we haven't thought about, which is results. In other words, I think technology can help us understand, because there isn't going to be one VBID design, and I think in all the organizations that the centers work with, everyone has their own unique design, and I think that means results and outcomes are going to be different. And it would be nice to be able to sort of understand what the actual outcomes are and what specific interventions they're related to. And so I have, since I'm not really speaking, I can give a challenge to my panel members. And one challenge, and these are challenges that I see that are technology related. And I can tell you that I've only seen one of their slides, a deck. So I don't know whether the other one is going to answer these challenges, so who knows, maybe they're already answered. But one is, I think we need to avoid false prophets and false promises. Technology has come out with all kinds of things that, supposedly are going to help us. For example, my company and many other companies, I don't see anybody from my company here, one person, so I can say this. We make predictive models. Well, supposedly we're going to be able to predict what members are going to cause problems from either, or going to be an issue from either cost perspective or utilization perspective in the following year. And how many of you are in that business? Some of you in that? No? Maybe one person? Well, we have a way of sort of saying how accurate are those. We call it R squared as one measure. So supposedly Millman makes the best in the industry, and it's the R squared is 0.29. What that means is going forward, where we can accurately predict people 29% of the time. So it means we're wrong 71% of the time. So for me, that's part of the false prophet. Now that may be the best there is, and I'm not going to argue with my Millman colleagues who create those tools. That may be the best there is, but still, it's not honest. Selling that with the implication of we're going to have this technology that's going to identify all the right people that you need to pay attention to. It may be better than nothing, and I'm going to concede that. But I think that's one of the important things for my technology colleagues to more or less, be able to address. We don't want to have false prophets, and we don't want to make false promises. We want to be transparent and tell it like it is. The other thing I think is that where technology can help us on the outcomes is to expand the evidence base. Now, if I ask my colleagues at the center, how many interventions do we have good evidence for that actually make a difference, and they are high value? And the answer is probably less than the 15% that we saw up here. And to be real honest with you, we've only looked at, those are the easy ones. Those are the easy ones. There are hard ones, really harder ones that I think only technology can help with. And I'll give you an example. One example is how many visits does someone with hypertension need in a given year, primary care visits? How are primary care visits linked to outcomes? Anybody have that answer? No. I can tell you that the average number of primary care visits that people with uncomplicated hypertension have incurred in terms of utilization over the last 10 years, it's doubled. You know, and I don't have any, I can't tell you whether our control of hypertension is improved or not, but that's the kind of thing that I think only technology can help us with. And with that, with that last comment, I'm going to turn it over first to Jeff, and then, since I'm filling in, I already forgot who was on my panel. Tom.
Well, good afternoon, everybody, and I want to thank Mark and Mike and the center here for sponsoring today, and I want to thank all of you for hanging in there. It's a long day, and really all the last of the panel can do here is keep you entertained. I think most of the key points have been made, but I'll try to spice a few things in there as I go along. One little fun fact, Mark and I went to medical school together, and it was VBID that brought us back together. I had not seen him for many years, and lo and behold, I was asked to be on his advisory panel, and he said, "Do you remember me in medical school?" And I said, "Yeah, you had hair." You know, so, no, well, Mark, you brought up your hair joke, so I'm going right there. All right, bring it. And I'm from the left coast, not the west coast or the east coast, but I'll say my color preferences tend more toward red than blue, so I'll just leave it at that. There we go. Thank you. I got one fan in the audience. One thing I wanted to say, just to pick up on a few comments from what people have said already, and I think Peggy said this for sure, and I think some of the earlier speakers, these things need to be bundled. The company I work for provides technology for any number of processes, claims administration, payment. We have a value-based benefits design product. We have a payment bundling product for providers. And the reality is, unless the leaders and the innovators start to think about pulling these things together, it will become a tragedy of the commons. It will be, people will have strategic imperatives that don't line up. And one thing I can say with confidence in working with literally hundreds of payers and integrated delivery systems, they're overwhelmed with things just like ICD-10 implementation and 5010. And so when you get down to the technology and what it can or can't do, it almost becomes like it is on this program, the last gasp. It just freaks people out because there's just too much to take on. So the more that these programs can be brought together as a package, not just because they make sense, but because the people that end up implementing them don't have the resources or the time to do them, it's better for all of us if we say VBID or whatever acronym we choose to use has to be part of the physician payment structure too. So programs that link the benefit design with the PCMH programs and the incentives are really going to be much more helpful to the people that are trying to make these things real on the ground. And I applaud what Blue Shield is doing, a former employer of mine, and those kinds of things where putting those pieces together, as hard as it is really going to help in the long run. The other thing I'd say, it's kind of interesting, is a fun fact that the technology panel has 2 doctors on it. So I don't know what that says about our career choices, or the way I interpret it is, all of us are trying to solve problems. We're not looking at technology for technology's sake, or at least I hope we're not. Technology is an enabler, but I think if you go very far in any of this, you pretty quickly find out you can't do much that's truly sophisticated or even scalable without some technology. So one of the things that I hope you understand is you can build all kinds of value-based programs without technology. We heard about a number of them today. Simple tiered benefits you can do in most claim systems, give everybody zero copay for preventive health. That works. I want to talk a little bit later about the reference pricing program that's emerging in California that I hope all of you at least heard about. So it's not impossible to do this, and it's not maybe even hard, but you know, the phrase, don't let the perfect be the enemy of the good, well, don't let the expedient be the enemy of the good either. I think there's a point where people need to understand why these programs make sense to them as individuals, not just as members of a population or not just as members of a disease group. And so some of the, I think, analytics that go with that, and we're not an analytics company, so I'm not saying this in any biased sort of way, but some of the analytics that help you predict and target who you're going to incent and how you're going to do that are important, and some of the automation tools that are really basically what are going to facilitate the consumers actually engaging. Once you offer the program, how do they keep track of what they're doing? What do they get for what they're doing? Do they get things that they want to get? couple of programs that I've seen people go through a fair amount of work to get to a point where they get maybe a $10 gift certificate to a health food store. Well, you know, believe me, if you go through all the work to do that, you want a gift card to REI, or you want something that you actually care about. Maybe it's health food store, but I think a lot of these incentives have to be tailored to what the people on the end that are doing the work want, and also when they want to get it. So I don't know about you, but we're in a 100% CDHP health plan. We have all kinds of incentives for our employees. I'm also the medical director for our employees. We have seen a lot of uptake on the HRA programs and some of the basic biometric programs, but the people that need it most actually don't take up the engagement programs that would help them. So I think one of the things we have to think about is what are we throwing into the system, and is it sticking? So I don't know if I have a clicker, so I guess I'll do the, is that right? That didn't work. Okay. There you go. Okay, everybody's.
We need Mark's
Yeah,
phone.
Mark, you got your phone there. Okay. So, you know, this is all pretty basic, and again, preparing for this, I would assume that most of the speakers would touch on this, but I think the main thing to point out is targeting is very important. And it's pointed out that the R-squared for, predictive analytics is actually relatively low, and that's true. But some of the basic stratification that most analytics companies can do now can at least give you an idea of where to put your dollars and how to incent people in ways that they're going to respond to. So if you've got a limited budget and you put it all in a wellness program for a population that has a lot of chronic illness, you're not going to get very far in terms of at least the immediate goal of cost savings plus improved outcomes. So I think there are some tools that people can use. You probably don't want to overuse them, but on the other hand, to not use any sort of analytics or any sort of measurement at all about where you are and where you want to go as an organization is a little bit risky. And I put the word chronic condition in here for a reason. A lot of the programs, I think, by design have started with wellness and preventive health, and that's all good, and it's all important, and people with chronic illnesses need preventive health too. But obviously, the real impact is going to be on those with chronic conditions. So at some point, we all need to roll up our sleeves and say, this stuff is hard. Not all the evidence is there. In fact, most of the evidence isn't there. But what we do know, we can drive in a positive way if we put a little bit of thought and sophistication in the program up front. Identify those with optimal evidence-based medicine care. And again, I'll say, in all sincerity, most of the things we want to do don't have a lot of evidence. I used to run a technology assessment process for a large blue plan, and over again, the challenge was to do double-blinded studies or even reasonable studies to prove a point is very long, it's very expensive, and most people don't do it. So if the default is we're not going to do something because there's no study, then we'll probably not do as much as we'd like. And the other point on identification is make it the individual. A lot of the more newer value-based benefit programs target classes of services, and I don't think that's bad necessarily for a positive incentive, but we've had lots of conversation around sort of negative third tiers that go to targeting types of services like MRIs or emergency room visits. Well, the quickest way to kill a program is to tell somebody that needs an emergency room visit that they have to pay $500 for it, especially somebody with chronic illness. So I think one of the things we want to think about is individuals as individuals, not as members of disease groups or not as categories of patients that where they don't have an affinity with other people in the category. The other thing is benefit enhancements for compliance rewards. I'll say a little bit about that, but again, giving people the types of incentives they want in the way they want it when they want it, and that's actually very difficult. All of these things go to the challenges of automation, but getting a premium reduction on next year's insurance contribution means absolutely nothing to any of us. It doesn't mean anything to me. I pay thousands out of pocket in a CDHP plan, and somebody's saying you're going to pay $14.97 less per pay period next year if you do this doesn't mean a lot to me. And I think it was somebody earlier that said, not only are those all forward rewards, but many of us in an automated environment, I don't look at my pay stub every 2 weeks. I don't know about you. So I don't track the minutia that goes on the pay stub in terms of what deductions or puts and takes I get. So we have to think about people and how they are behaving, especially in a digital age. And I just joined Facebook, by the way. So if anybody wants to friend me, I need a few. My daughter said to me, you'll be humiliated. That's what she said to me. So I love my daughter, but I got 5 so far, so I'm really happy about that. And then last, and this is brought up over and over again, you've got to get this connected to the physicians and the other delivery system reforms and other payment reforms that are out there. We do a lot of work, and I'll tell you from our customers and how I see it, payment bundling and episode of care payment and PCMH, those are hot topics. That's what people want to talk about, whether it's a large payer or whether it's a delivery system, an IDN, a hospital, and that's great. But to get value-based benefits, and I'm using benefits, not insurance design, on the table, we almost have to attach that to those reforms to make it real. So if you're going to do payment bundles about knees and hips, that's great. How can we connect that to employers in those areas where the delivery systems are willing to take bundled payments and warranties, and how do we track that through the system? And I used to be health plan chief medical officer. For those of you that work for payers, don't answer this, but take a guess how many different versions of a PPO we had. This was 8 years ago. It just range. I think up to 200. Anybody? More than 200? Okay, 1,700 for just a PPO product. And that goes to every employer and every benefit design that plan had to administer for the customer base it had for a 2 million member health plan. So imagine tracking all of that through to every single one of those employers, getting their permission to make those changes. So if you're going to do this, offering a new product is the way you got to go in some ways. If you're going to do this for existing customers, if you're a payer, it can be a nightmare. Now imagine if you're a large delivery system or provider and you don't even have access to who your payers are. So that's another challenge. The other thing I'd say about connecting the dots, a lot of the reform proposals around a delivery system reform, they're not only silent on benefits, but they're actually negative on connecting those reforms to the benefits. So if you think about the ACO regs as one example, the improvement they made in the regs recently was that at least the ACOs would get a prospective view of who would belong to their ACOs, but they absolutely will not let the ACOs touch those members and tell them that they're in the ACO. So the whole theory of the case is you can't interfere with beneficiary choice. So if they want to play outside the ACO, they can. They can go anywhere they want. Well, from a payer's point of view, that's called leakage, and that's where your biggest costs are and your biggest problems are. So somewhere along the line, we've got to be able to connect these delivery system and payment reforms to the people that would actually benefit from them and be incented to use certain systems and not others. Because at the end of the day, you can trim benefits and change them all you want, but the things that matter to cost are essentially the network. And you see that in Massachusetts in the exchange rates and everything else. The narrow networks actually are where a lot of the cost savings are delivered. So as long as those provide high quality and maybe better access, then that's where you want your individuals and your employees to go. But if we can't do that, then there's an enforced disconnect between the delivery system and payment reforms and the benefit design that we're trying to push. Okay. I'm only going to do, I think, one more slide in the interest of time. Oh, this is a build, so I get to clap a lot. This is sort of where you guys warm up. Is this at least keeping you entertained? I said I'd do that much, right? Okay. Oh. Okay, I did this one myself. So this is where the doctor is not the technologist. It builds from the middle to the top to the bottom. Okay, so it keeps, you like this? Okay. All right, I already alluded to this, but the third rail of disincentives for preference-sensitive information. This is a kind of a long-winded way of saying there's a lot of things we don't want people to do. Too much imaging, too many ER visits. The real trick to that is sometimes it's really necessary. Sometimes an MRI is a good thing. Sometimes going to the emergency room is really, really necessary. So the trick for value-based design really is how do you discriminate between those many people that abuse that out of convenience or ignorance or whatever else versus those few people, especially those with chronic illness, that may need that. And so I think one of the things we have to think about is in our zeal to do this and to implement this, that we not put in barriers or perceived barriers that actually drive people away from these designs. And the Oregon plan was alluded to. Some of our customers work in Oregon. One of the interesting things is a lot of people are taking that three-tiered design, and Mark was involved in this, and they're actually modifying or eliminating that third tier because it's such a barrier to adoption for a lot of employers because it just looks too scary. And it may not turn out to be scary, but it actually doesn't feel right going in. And the title of the slide is really some of these things are you can overcome with technology. That's what technology is supposed to be there to help you to do. If you got a problem, can you solve it? But that requires actually getting down to both not just the plan level and not just the member versus subscriber level, if it's a payer system, but also the individual. So what condition do they have? Is their pursuit of an ER visit or an MRI necessary? And if so, how can you make sure they don't get pegged for that big disincentive when they actually need it? Okay, how are we doing? So I do it fast, you get done early, and then I get the clapping started at the same time. Assuming compliance improvement is the same as proven ROI, we saw a lot of studies earlier today, and it was a really nice list around the impact of benefit design and incentives on compliance, and that's great. One of the challenges, which we heard this afternoon, we're starting to break through, is what's the actual ROI? So again, connecting the improvements that we seek hasn't necessarily meant there's a lot of information around the even medium-term contribution to cost savings. And as we all know, that's kind of the name of the game. I think most people that have spent any time with this understand there's some upfront costs. Recovering those costs and actually sustaining those cost improvements over the long term is really where more work and study needs to be done. Okay. Tiered benefits masquerading as value-based benefits. Masquerading is kind of one of those words that you throw out to see if people are awake. Actually, the glow on your face tells me you are. I guess that's your blackberries in your lab. But I bring this up because a lot of times I think people think that getting something started is where it should stop, and they should rightly feel proud of that. But a lot of times, simple tiered benefits don't get to the nuance of individuals and their care needs. So it's fine to give away good stuff for free. Everybody should be incented to get colonoscopies and other preventive health things. It's fine to not change the plan around the things that are actually working in the way that they're working. But it may be difficult to do these disincentive programs, and it may be actually fairly easy to do things that really matter, that really have nothing to do with evidence-based medicine. I'm going to use another California example. Where I live, there was a study done by an employer that showed the low end for a routine colonoscopy cost, total cost was $1,000. The high end was $8,000 within a 20-mile radius. So it isn't necessarily about what's the best care. It's where you're going to get it. I think Alan made that point earlier. You can save a lot of money. You can have a very important and valuable contribution to the value-based movement simply by helping people pick the right place to get care, whether that's a PCMH program or not. And if you want a kind of a technology-light program, I would suggest look at the true costs of your network, the out-of-pocket costs to your employees or your beneficiaries, and say, where can I direct them in a thoughtful way so that they're actually going to save money? And last one, BBID programs for wellness only. I think it's great. We got to start with the low-hanging fruit and all the analogies that we use. But if this is really going to hum, and if it's really going to hum for cost savings, it's got to be directed at chronic care. It's got to be directed at those interventions where there's high costs, like total knees and total hips. And that gets to be the harder part of the equation because now you're starting to need the analytics, even if the R-squareds are bad. I'm sorry, I jumped on that. The R-squared for the contribution of high cholesterol to heart disease is about 0.29, I think. So, that gives you an idea. Evidence-based medicine and the predictive analytics we use are kind of in the same ballpark in terms of their scientific validity. So we have to start using some of the tools that we have, I think, to be a little bit more predictive along the way. And I'm going to skip ahead because I know my time is done. All good, all good. It's in the pack, and there. So if you want the laundry list, the technology laundry list, and these are very, very difficult and important things, and these are the things that my company has been trying to solve for. Katie Nevin is here. She's the intellectual, Katie, can you raise your hand? She's the kind of one of the intellectual architects behind solving a lot of these problems, but you really have to think about designing programs with rules that you can automate. That's one thing. You have to relate those programs to the members and how they interact with the system, whether that's through the web or through mobile tools. You have to identify the populations of interest, goes to analytics, and not just the diabetics, but sort of the complex diabetics and stratifying the diabetics. You've got to be able to enroll, something as simple as enrolling people. How do you do that? They enroll once a year for their benefit plan. What do they do to enroll in 3 different weight loss programs in 3 different cities because you're an employer that works in 3 different markets? How do you do that? You've got to be able to track. There was a lot of comment from the gentleman from Connecticut. How are you going to track all this? Not only like who signed up for the program, but who actually did what they said they were going to do. And did that have the effect financially and otherwise on the outcomes? You've got to identify that compliance. You've got to figure out what types of reward types. Do you want to put it into the HRA and HSA accounts? Do you want to give gift cards? Do you want to give cash? One of the most interesting demonstration projects was the ACE demonstration project that CMS did, where half the savings went back to the beneficiary. So, that got the beneficiary's attention pretty fast. Unfortunately, they haven't kind of carried that incentive program into some of the newer demonstration projects. You've got to be able to administer specific benefits, and so one of the technology challenges is if I have a group of subscribers in a plan, how do I identify a small group of them at the member level, not the subscriber level, without forcing them to join another plan if they do the right thing? So there's a lot of technical challenges there. And then you've got to be able to present the program content, status, updates, allow people to interact with the program along the way. I want to monitor and improve my health, maybe weekly, not every year at open enrollment. And then you've also got to be able to allow the members to track their activity themselves. So that's a long list. The positive news is there's a number of companies that have got technologies that'll do most of these things now. So it's not that the technology is necessarily the barrier anymore. It's just how are we going to apply that technology to the people that we want to see the most impact on. So thank you very much. Sorry, it's a little bit of a rush.
Thank you. Well, aloha.
There you go. There you go.
That's a weak aloha back. Aloha. Great. Thank you. Well, it's only 10 o'clock in the morning for me, so I'm just waking up. Well, when Mark called me a couple months ago and asked me to do this in substitute for Aaron McKeithen, the director of the Beacon community, I actually Googled VBID, and I found an article that Mark and Mike wrote in 2007. And I have to really give kudos to both of you guys. Now, you guys are true visionaries. In 2007, they said HIT and health information technology would be needed for VBID. And this is way before high tech. So I'm going to give them, a round of applause because you guys really foresaw the need for HIT and way before Congress did. So thank you. So I'm here to shed a little bit of information about HIT and its impact and its need for VBID. But I also want to talk about that in isolation, it probably doesn't do very much. Again, this running theme that it needs to be bundled with reform in terms of payment policies and also reform in terms of the delivery system itself. So a little bit about high tech. I think most of you know about the high tech framework. So I spent the last year and a half at ONC before I moved over to Hawaii. And it's not because of Farzad, but Hawaii really presented a petri dish of an environment where there's a really great test bed for innovations, and it was a wonderful opportunity to do it with palm trees and 86-degree weather. So high tech. The framework is ONC has promulgated roughly $2 billion worth of programs. Regional extension centers, about $600 million or $700 million, going to 62 regional extension centers across the country, helping about 100,000 primary care docs adopt EHRs in a meaningful use manner. Medicare and Medicaid are giving incentive dollars from $44,000 to $63,000 to providers. Hospitals are getting $2 million with absolutely no ceiling in terms of EHR adoption incentive money. And then simultaneously, to create the foundation for exchange, there's a state information exchange program, roughly about $550 million going across the country, setting up the governance structure, setting up the technology platform to provide this exchange network throughout the country. And then there's standards and certification process, really thinking about getting, how do we exchange this clinical information from one end of the country to the other end? And it's really adopting the standards that are promulgated by the private sector And so there's a federal advisory council across the country really setting up the standards, and ONC is promulgating those standards. And of course, privacy and security is a concern, and I think it's about aligning state and federal policies to provide a trust environment so that patients can actually participate in exchange without worrying about having their information breached. So really, setting up this framework for the improvement of the triple aim goals that Don Berwick has been talking about. But what I really see is VBID, and the other two legs of the stool is really payment reform and delivery system reform. You really can't do one in isolation. And again, it's not just about technology, stupid, to someone, when I talk about to some of the folks who think about just getting money to buy technology, incorporating it, and they're thinking about doing organizational change or systems change just by adopting technology. But we really need all the other different processes in place to really improve outcomes and efficiency. So a little bit about payment reform. I think many of you know that we're moving and we're pivoting from paying for transactional payments to much more of outcome-based payments. Clinical measures, and this is, I worked with Peggy and her organization and QF in terms of thinking about quality measures and quality strategy, at least from within the HHS enterprise, with value-based purchasing, with PQRS, with meaningful use. And as we pivot from claims data to electronic data, this is where you're going to get this plethora of information. And as Todd Park talks about data emancipation and liberation of data, I'm talking about alignment of data. And we need to align data to really do the things that Jeff is talking about. So this is a slide about hospital payment interactions. Hospital-acquired infections, there's 0.02% reduction in the DRG rate, as well as meaningful use. So meaningful use, there's a carrot and a stick. So the carrot is, we talk about the upfront money starting this year, but then around 2015, moving upwards to 2017, there's going to be reductions in the market basket updates, as well as hospital inpatient quality reporting, which used to be known as RACTAPU. They rebranded it, thinking there's going to be increased participation now. So now it's called the hospital inpatient quality reporting, and there's a 2% reduction. So all of these different policies are really forcing the environment, forcing the stakeholders to think about EHR adoption. Because a lot of the quality measures that's going to be reported will be shifting over from claims-based to electronic measures. Same thing with the providers. Providers will have at first a carrot, and then at the end it will be a stick as well. And then along with meaningful use penalties, it kicks in with 2015 and then moving outwards to 3% in 2017. So in terms of hospitals, they could be losing millions of dollars, and then providers will actually be losing potentially 3% of their revenue if they have a large percentage of Medicare. So that's the policy environment. We're going to move over to system delivery redesign using HIT. And here I'm going to be highlighting the Beacon communities as really a showcase and test beds for some of the things that we're seeing. So the Beacon communities is an ONC sponsored project. There's 17 across the country. There's actually one in Michigan. There's Southeast Michigan. Each of them have received anywhere from $16 to $17 million. And it's about, again, using HIT to enable the organization to actually change their processes to improve outcomes and improve quality. And some of the things that they've incorporated in terms of using and adopting technology is particularly transitions of care. So how do we digitize Eric Komen's model? How do we digitize Mary Naylor's model? And in terms of the readmissions, everyone's talking about readmissions and reducing the 20% of readmissions and the congestive heart failure readmissions. So how do we get the discharges as they leave the hospital and doing the medication reconciliation? How do we get information from the hospitals to the receiving provider? And how do we do it with EHRs? So a lot of the Beacon communities are actually demonstrating that it could be done in transitions of care instances. Care management, many of the beacons are actually training individuals with protocols in terms of creating self-management plans, patient activation. The next thing is computerized decision support. I think we're going to see a lot more in the future about clinical decision support. I think the one thing that we're missing right now is we're missing an NQF for CDS. We don't have really a peer review process that actually endorses CDS. So I think we're not seeing very much movement in that community, although NIST is doing a lot of work and AHRQ is doing a lot of work. We need a kind of like an NQF endorsement process and peer review process for CDS. One of the critical areas is physician data feedback. Now, I don't have to tell you that PQRS, how many of you have heard of PQRS? So it's a physician quality reporting system. It used to be known as PQRI. And for reporting of 4 to 5 measures, the provider gets $3,000 to $4,000. So the caveat is that they get the feedback back, take a guess, 2 years. Not 3 months, not 6 months, not a year and a half, but anywhere from 18 months to 2 years. And so by that time, the patient could be dead. I mean, come on, right? Seriously. So PQRS right now, we have 150,000 providers. 100,000 are participating through claims, 55,000 participating through registries. We're going to see a movement towards EHR data, and hopefully CMS could get their act together and actually give feedback back within a timely basis. And I think that's what the beacons are trying to do that. They're working with CMS to actually combine a lot of the claims data as well as the EHR clinical data to provide this physician feedback back in a really timely basis. Public health registry measurement, reporting labs for surveillance, bioterrorism for surveillance, and immunizations. So I think that's going to be critical issues. I read somewhere that Michigan right now, you have roughly about 10% diabetics, and you spend roughly about $8 billion for costs going towards diabetic care in Michigan. So that in itself is a huge public health epidemic that needs to be countered in Michigan. I don't have to tell you, if Jeff has joined Facebook, I don't have to tell you that there's millions of other consumers that have joined social media networks. And, you know, the providers are the last ones to adopt technology, of course. So consumer e-health is going to be a critical driver in all of this. And so the beacons have realized that. And so these are some of the demonstration projects that's going on that's actually taking in data directly from patients, and there are instances where you can actually utilize this data in VBIB. So remote patient monitoring. So there's a demonstration project going on with California right now paying for telehealth. PHRs and patient portals. There's 5 beacons that actually set up patient portals, and Group Health is actually one of the leaders in doing some of this work. mHealth in terms of public engagement. So North Carolina is actually piloting this program called Asmopolis, where they've embedded a RFID chip into the inhaler, and once the patient uses the inhaler, it sends a signal back to the provider telling them how many times the patient uses the inhaler. And it also goes through a smartphone device. So when you get that type of real-time data about medication adherence, you could actually design interventions focusing on the ones not using the inhaler, and of course, dropping out of the system. So that's really innovative use of real-time biofeedback information. And then patient engagement, there's a huge initiative going on with HHS using the makers of Text for Baby And also there's this Text for Health initiative going towards smoking cessation. So a lot of the beacons are leveraging some of the HHS activities. And then lastly, patient-reported outcomes. Peggy didn't, I think, mentioned it briefly about this, but there's a movement right now really going towards, as we design value-based purchasing payment policies and looking at the outcomes of provider performance, we should ultimately, look at outcomes reported by the patient. And so there's a movement towards designing quality measures such as SF12, SF36, the functional status measures, PHQ-9, and really targeting these directly to the consumers through the patient portal or through the smartphone device. So what's happening with VBID and technology? I think this is really, we're seeing the reality of the transitioning from science fiction to things that are being piloted in test sites, and the use of a fine scalpel rather than a saw in terms of implementing VBID, where you can actually differentiate a tiered system, especially formularies, using clinical data in addition to claims data. So, for example, EHRs and health information exchanges will give you information on smoking status, family history, past history of heart attacks, adverse reactions to meds, lab results, and all of that could really add to the predictive model. There's a hospital, one of the largest public hospitals in the country called Parkland, that's actually created a predictive model based on social economic data in addition to clinical data, and they could actually predict the frequent flyers in terms of who's going to come in for the second admission. And it's all based on some of the social network data that's out there. So whether the person is homeless, whether patient, what zip code they're living in, how many family members are listed as emergency contact, all those different points add up to information that Parkland has created in terms of predictive modeling. Now, coupled with genomic therapy, now Medgo has created a predictive modeling tool that looks at P450 drug metabolism. So in other words, all of us sitting in this room, we have fast drug metabolizers, we have slow drug metabolizers. Not every drug works the same way in each of us. We're all heterogeneous in terms of genetics. And so I might acetylate or I might metabolize a beta blocker for my heart attack much slower than Mark. And so that's important in terms of the dosing as well as the type of drug. Now, Medco has and is partnering with a company that actually has created that database of acetylation rates and also the drug-drug interactions. And you can do this in real time as you look and pick at formularies. Scary, yes. Patient-reported outcomes. So I talked about PHQ-9, SF12, 36, patient activation scales. So a lot of this information is extremely going to be relevant in coming up with predictive models as well. So this is what an EHR e-prescribing module might look like. So as a physician prescribes the medication and looks at the list of antidepressants, there would be the co-payments, and you can see that all of them are $5, and over here maybe $20. So this is Ritalin. This is Lexapro. And this is I forgot the brand name for this drug. What's that? It probably is too dangerous. So basically, right now, our copays are determined by the ingredient or service cost, not really the value. And in the future, we can actually combine all this information and actually create different copays based on the effectiveness based on the information and really based on your patient characteristics. And since this is happening real time, you can have the patient sitting there at the point of service, and you're sharing information with the patient, and this is the activation part, and this is the shared decision-making part as well. And so you really could hone in and design a benefit package or a tier system where the dangerous drugs, in terms of whether it's metabolism, drug-drug interactions, or a family history of suicide, where you don't choose the dangerous antidepressants. There's a company, Invita, that actually has patent-pending technology that's actually doing this. Simultaneously, they're determining the cost of each therapy, the effectiveness of the therapy, and then at the same time, really looking at the complication of therapy, and all creating an engine tool for the providers. Another company has really created the follow-up to that in looking at a technology that can actually predict adherence. So they're taking all these different multiple points of data, claims-based, clinical data, and they could actually predict with a relatively high specificity and sensitivity those patients who would actually fall through the cracks in terms of patient adherence. And then you could fine-tune your intervention model. So at the end of the day, you could target these type of patients as opposed to looking at patient X, which would benefit in terms of this intervention. Oh, actually, it's the other way around. We want us to be here as opposed to here. So some of the companies that I've listed actually are piloting these things, technologies with some of the clinical sites around the country and with some of the beacons as well. So at the end of the day, I think this is an extremely exciting era for VBID, and I really call it VBID 2.0 as we move from claims-based data to electronic data, and I think this is where I'm going to end. So thank you.
I'm informed that we have time for 2 questions for the panel. No questions? Okay. Well, we met our goal. Thank you very much.